Alrighty. Okay. All right, number 2. I like that. That makes me happy. Even the kings. Inversion. Inversion. Arms and legs, hinges, appendicular, hinges. Are the muscles to bone? What structures are important for connecting bone to bone? Ligaments. Very good. All right. Great to see who's going to get it. So the ulna, this is your ulna. The pinky side lines over your ulna. The ulna is distal. Oh, coach him snuck in on him. Finish it out. You will win, sir, by default. The computer will say that you will have won. All right, a little bit of fun. All right, so now we're back into chapter 4. Any questions before I begin? Any questions about the quiz? Any questions? Online people, any questions?
I'm trying to type fast, but I can't. But can you explain the ulna and the humerus question again?
So when you look at the humerus, so when we're looking at the human skeleton, the humerus is here, the ulna is going, so it's more distal, it's further away from the midline. Remember, distal proximal speaks to how close to the axial skeleton. So it's further away in anatomical position than the humerus. That make sense? Can you hear me?
Yeah, I get it.
Oh yeah, so it's further away. So it is more distal. Good question. All righty. So let's get ready. We'll pick up on chapter 4 again. Trying to get you guys more info there. We'll start back lecturing that. Let me get my Zoom people able to see. There you go. My online people, can you see that?
Yes, sir.
My in live person people, can you see that? All right, so here we go. Chapter 4, let's dive in. Again, it says, get my mouse. So again, it's talking about joint movements. So remember, a joint is simply the connection between two or more bones. So when two or more bones articulate or connect or are in close proximity to each other, they will form a joint. So two bones articulating, articulation is the word that they use, but when they approximate or they're near each other, they will form a joint. Okay. The book says joint movement is thought of as one bone moving on another one. These movements, which are done under voluntary control, are termed osteokinematic motions. So remember, we talked about kinetics, which are the forces that cause movements. We talked about kinematics, which are the movements themselves without concern for the forces that cause them. So osteokinematic movements, when I can describe what's happening at a joint, is called osteokinematic movement. My arm goes up like this. That's osteokinematic flexion. My arms go out to the side like this. That's osteokinematic abduction. If my head bends like this, that's cervical side bend to the right, osteokinematic movement. So osteokinematics is simply the description of movement of the body. Okay, so when we move, there are descriptions. Okay. It says osteokinematic motion can occur actively or passively. Remember, we said active movement is when I am performing the motion. I lift my arm up. I'm doing the movement. My muscles contract and they make me move. Whereas passively, either someone else or other muscles from my body is causing the movement. So if I take my arm and I use a pulley and I pull down with my good arm and it pulls my other arm up without me using any muscles, that's still passive motion. Make sense? So passive motion doesn't have to just come from an outside source. Okay. Okay. So we said we do passive motion so that we can find what's called an end field. So that's what we were doing last time we were here. We were showing you how to find end field. And remember, end field is the feeling that you will get when you passively move a joint through its full range of motion and then push slightly beyond that. So you'll go as far as the motion will allow you to go, and then you'll push slightly beyond that. And that will give you information about the end feel of a joint. Every joint, whether normal or abnormal, will have an end feel. Okay. Every joint, whether normal or abnormal, will have an end feel. So if it's a joint, it's going to have an end feel. Okay. The book says a normal end field exists when there is full passive range of motion and the joint is limited by the expected structures for the particular joint. So if I'm expecting a bone to stop the motion from happening, I should feel bone stopping motion. If I'm expecting a joint to stop it, then I expect to feel joint stopping motion or ligaments and tendons. If I expect soft tissue to stop the motion, then I should feel soft tissue stopping the motion. Okay. Says abnormal infields are present when there is both pain, so we know what pain is, we don't have to describe that. Muscle guarding, that's when the muscles around the joint are tight and spastic and are painful. Have you ever, let's see here, anyone ever woke up with a crook in your neck? Everybody has. Great. That's a muscle spasm. When you went to try to move your neck, you were waking up and your neck would move. People called your name and you were like, what? Don't you see I'm hurting? You try to move your neck, you go, ha, ha, ha. The muscles are tight and they're spastic. So that's a type of muscle spasm, okay? Or muscle guarding. Swelling could be another one. If you've ever sprained your ankle really badly or bumped your knee into something really hard and you look in and it's swollen, like, ooh, the thing is swelling up. Or abnormal anatomy. We won't get too deep into that, but you can have what's called abnormal anatomy. Bone growths that are not normal can cause this. So you have bone growing where bone shouldn't be growing, and that can cause abnormal infield. Okay. The book tells us there are 3 types of infields that are normal. So when we're looking at infields, there are 3 types of infields that are normal. So 3 types of infields that are normal. Number 1, the first infield that is normal, the book will tell us is going to be a soft infield. Soft infield. We get a soft infield when we do, it's called tissue approximation, or where muscle meets muscle. So soft infield is going to be when muscle meets muscle. A couple of places where we see this, really about 3, where muscle meets muscle. Elbow flexion is going to be 1. That's where muscle meets muscle. That's a place we see that. You go into elbow flexion, your proximal forearm meets your shoulder. Elbow flexion. In knee flexion, your proximal calf muscle meets your hamstring, the back of your leg. And when we do knee to chest for hip flexion, so if I lay you down and I try to bring your knee to your chest, it's going to limit how much hip motion you have. So that one is not always. So that's why I say there's 2 primary, 1 potential. Okay. So that's called a soft infield. The next one we'll talk about is called a hard infield. Hard infield. The infield that's most relevant to a hard infield is going to be elbow extension. So everybody try to extend your elbow. Like really, so don't just nicely roll it out there. Like really try to throw it on out there. Oh, ow. The reason it doesn't go any further is because you have an actual hard infield there that's limiting your motion. When I extend my elbow out, it feels like it's banging into something. That's a hard infield. Okay, so that's a hard infield. Okay. Yeah. Okay. So hard infield. Trying to stretch my arm all the way out. Feels like it's banging into something. Out. Hard infield. The rest of the joints in the body are all primarily firm infield, which is going to be due to either ligaments or tendons or some other tissue stopping the motion. But it won't be bone and it won't be soft tissue. So it's either the joint capsule, ligaments, or tendons that prevents the motion from going any further. That's a firm infield. So those are the three normal types of infield. If I'm extending my elbow, that hard infield I feel there was a bony stop, that's a hard infield. If I'm doing elbow flexion, I get soft tissue approximation from my forearm and my bicep. That's soft infield. Everything else is going to be primarily firm. Easy way to remember. So if it's with the neck, most of the shoulder stuff, the wrist stuff, all of these are going to be firm. Hip stuff, knee stuff is going to be firm because ligaments are going to stop that motion. You'll see when we get to the knee, every knee doesn't stop at the same level. Some of your knees are going to extend further than most people's knees. You'll have what we call hyperextension of the knee. So even though we think the knee would have been a hard infield, it's really not. Ligaments do the job of stopping the knee. Okay? Any questions? Good there. Okay. So that. Okay. So the book tells us, page 32, any of the normal infields can be considered abnormal if they occur at the wrong joint or if they occur at the wrong point in the range. So all of these can be abnormal if they occur in the wrong joint or at the wrong time during joint movement. So if I'm not at the end range of motion and I feel something that feels like an end range setting, then I have an abnormal joint. Okay. It says some infields are always considered abnormal and may be present when there's pain, muscle guarding, swelling, or abnormal anatomy. Abnormal infields are usually described as either boggy, muscle spasm, empty, or springy block. Those are the ones that we can describe abnormal infield. Bony as well, but the book doesn't put bony. But a bony infield would be if I have bone growth. Let's say I have bone growing on my elbow, excessive bone growth on my elbow. I fell, I fractured my elbow. Now I have what's called heterotrophic ossification. Abnormal bone growth in my elbow. I go to try to extend it and I get a block. It's like it feels like bone. bone meeting bone, just like this would feel like bone, but it's abnormal. That would be a bony block. Boggy infields are going to be when you have sprains. Anybody here ever really sprain your ankle or bumped your knee really hard? You get some swelling in the joint. Anybody ever have swelling either on your back? You injure your back is swollen, or your ankle is swollen, or your knee. These are ones that swell easily. So if you've ever had swelling in an area, you go to touch it, it feels like it's puffy. Like, ooh, that's puffy. That's a boggy infield. It feels puffy. I can't get to the end of the range because there's so much puffiness around the joint. Okay. So that's kind of the boggy. Muscle spasm would be just like what we talked about earlier, guarding. If you have a crook in your neck, so if you have a crook in your neck, that's a muscle spasm. The muscles are spasming. When you go to try to pull your neck straight, it pulls you back to where you normally are. So you go to try to straighten your neck, pulls you back. Spasm. It's tight, sore, it's hurting. Empty infield is going to be when a patient doesn't even allow you to get through the full range of motion, usually due to pain or fear. So if I am trying to move somebody's elbow through full elbow flexion, when I get to about midway, they go, oh, I can't go any further. Oh, something miserable. Gotta lay it back down. Empty infield. It's empty because I don't get to the full in range of motion. So this is full range of motion like this. If I'm not able to get to that, I can only get to here, I'm left empty. So it's an empty infield. Okay. And then springy block would feel like a rebound, almost like when you bounce a basketball, how it bounces back towards you. That springy block, like when you're moving it, it feels like it's bouncing. Okay. Any questions there about infield? Okay, now let's move on to arthrokinematic motion. So we've done osteo, which is descriptive movement. So if I'm doing this motion, how would you describe it? Very good. I'll take it. Shoulders, there you go. Call the joint and call the motion. Elbow flexion. Very good. I'm not really rounding. Wrist extension. Very good. Wrist extension. Bring my wrist up like that. That's extension. It's extension when I'm going to the dorsal of my forearm. Flexion when I'm going to the palmar side. That will be flexion. Coming toward the palm. Very good. So those are osteokinematic movements. Osteokinematic movements. Descriptive movements that I can perform that I can have easily described into words. That's osteo. Now we're going to talk a little bit about arthrokinematics. Arthrokinematics are different than osteo because they are not concerned. Wrong direction. There we go. Here's my man. They're not concerned as much about what's going on with the actual motion, abduction. They're more concerned about what's going on at the joint here that allows for this to occur. That makes sense? So it's concerned, arthrokinematics is concerned with what's going on at the actual joint, at the surfaces of the joint, what's happening there. And it's concerned about that, what's happening at the joint that allows motion to occur. So if I don't have that, then motion can't occur. That's what arthrokinematics is concerned with. So osteo, descriptive motion, flexion, abduction, extension, pronation, supination, flexion, extension of the wrist, radial ulnar deviation. That's osteo. Arthro is going to be described in basic terminology based on what's going on at the joint. Okay, so let's dive into that. We won't get into too much of this. The thing that I want you to know the most is that when we're dealing with something called joint play, down at the bottom here, the accessory motion, it's the arthrokinematic movements that happen between the joint surfaces, and it can either be given in terms of roll, glide, or spin. So those are the three types of motions that happen in a joint to allow for motion to occur. Either roll, glide, or spin. Roll, glide, or spin. Okay, that's the major thing I want you to know. Okay, next thing we'll dive into is talking about joint surface shapes. Joint surface shapes. So most joint surfaces, well, let me stick with the book. The book says to understand arthrokinematics, you must recognize the type of motion occurring at a joint depends on the shape of the articulating or the connecting surfaces of the bones. So I need to know what types of shapes I am looking at, and that's going to determine what type of motion occurs at that joint. Since most joints have one concave bone and one convex end. So most bones are going to have a concave portion or a convex portion. Let's make that make sense. So most joints are going to have a convex or concave. So when we're talking about it, let's make this make sense. So when I'm looking at the femur here, the head of the femur is going to be convex. Means it rolls outward. So the head is projecting outward. Convex projects outward. The hip, the place where it's going to go, called the acetabulum, looks like a cave. Looks like it's caved in. You would go into this. So this would be a concave surface. So most joint surfaces are going to have a convex or a concave portion to them. And that makes it easy to understand how they're going to go together. You wouldn't put two concave surfaces together. There's nothing that'll hold them on. You wouldn't put two convex surfaces together. There's nothing that it will actually fit into. So I need both a convex and a concave surface, no matter how big or small, to create an actual joint. Make sense? So all joints will either be, so the next line says all joint surfaces are either going to be ovoid or sellar. Ovoid or sellar. Ovoids has a bone forming a convex-concave relationship. So that's going to be the one that we deal with the most, is ovoid joints. They have one surface that's convex, one surface that's concave. That's called an ovoid joint. One surface concave, one surface convex. Ovoid joints. The book says most synovial joints, so most of the joints in the body that are from the appendicular skeleton are going to be ovoid. In an ovoid, one bone is usually larger than its adjacent bone. This permits a greater range of motion on a lesser or smaller articular surface, or a smaller surface that the bone is fitting on. And that's going to reduce the size of the joint. So no better place to see this than if we actually show you. Hard to see it with the much easier. Okay. No better place to see this than if I am using an actual shoulder. This is the scapula. This is the bone here on the skeleton. So when we look at the skeleton, scapula, this bone here. So that's the scapula there. So scapula, and it articulates with a humerus. And what you'll see is the head of the humerus is much larger than the surface area where the head of the humerus has a larger surface area than the area of the scapula where it's going to fit. So you have a big humeral head, a small scapular area called the glenoid fossa. And that allows for the shoulder to have lots of movement and function. That's why it's so mobile, because the head of the humerus fits onto a smaller glenoid cavity. Now, they've exaggerated this one, made it a little bit bigger, but in actuality, it's actually a little bit smaller than even that. And the head of the humerus has to fit on there, and that's how it creates movement. That's a type of ovoid joint. Okay? It's going to be a convex surface and a concave surface. They're going to have a convex surface and a concave surface. A cellar type joint or a saddle type joint primarily occurs in very few places in the body. The primary one is going to be in the joint of the thumb. So the joint of the thumb is probably the most recognizable cellar joint. So these are, so it's going to be here in this joint right here of the thumb. And it's called a cellar joint or a saddle joint because unlike most joints where you have to pick convex or concave, it actually has both a convex and concave shape to it, all in one bone. So it's kind of like a saddle. It has parts that are convex, parts that are concave, all in one bone. That's why we call it a saddle joint. Pull the picture from the book, okay? Okay, so when we're looking here in the thumb, this joint here of the thumb, you can see here has a part that's convex on the edges, and it has a part that's concave in the middle. See that? So when we're looking, so right here, part of the projection it becomes concave. So again, with this bone, we have fiber is AZ. Same thing with the convex again. So it's shaped like a saddle. So this joint is shaped like a saddle. So it has a convex part, a cave-in part, and then another convex portion with both bones, convex, concave, back to convex. That's a saddle type joint. Okay. So that's one of the primary areas you'll see that is in the thumb. I won't get too technical with the name of it yet. You'll learn it when we get there. Okay, so the two different types of joint shapes. It's going to either be ovoid or cellar or saddle. You can call it cellar or saddle, either one. Most people call it saddle. So ovoid or saddle type joints. Those are the two primary joints in the human body. And they are going to help us understand how the body moves when it comes to the joints of the body. Okay. Any questions thus far? Question. Yeah. All right, it's a good place for a break. Take about 3 minutes. People online, take a break as needed. And we will be back in about 3 minutes and we'll pick up and really have some fun with it. All right, so we're back on it. Okay, so now what we're going to cover is one of the most important understandings you will have relating to how arthrokinematics work. So this understanding will literally set the foundation. So if you get it, you'll get arthrokinematics. You'll be fine. If you don't get it, it's going to hinder you. It's going to drag throughout the rest of the semester. So really hone your ears. This is the part, if you pay attention to nothing else I've said, this is the part you want to hear. Okay, so we're going to start talking about the convex-concave rule. Convex-concave rule. That's vital. The book says, knowing whether the shape of a joint is convex or concave is important because shape determines motion. Shape will determine motion. The convex-concave rule describes how the differences in shapes of a bone's end require joint surfaces to move a specific way during motion. The rule expresses the relationship or shows or demonstrates the relationship between osteokinematic movement we can describe, and arthrokinematic movements, what's actually happening at the joint. So this rule bridges both of these motion types together. Okay. So it says to properly analyze this, you must observe motion occurring at both two locations. The joint surface, where the moving bones are actually are articulated or connected, that's going to be arthrokinematics. And then the distal end of that movable bone to see the osteokinematics. What do I mean by that? So let's look at skeleton guy here. So we're going to do a movement. So when I'm looking at convex concave rule, I need to look at both what's happening at the joint surface, the arthrokinematics, and the distal end of the bone that's moving so I can determine osteokinematics. That makes sense? So looking at both, what's happening here is going to describe what's happening here. So when my shoulder goes into abduction, so going into abduction, there's movement occurring here at the joint that allows for movement to occur here at the distal end of the humerus. That makes sense? So if I block the movement at the joint, there's no movement that's going to occur here distal. Does it make sense? So if I don't have arthrokinematics at the joint, I'm not going to have osteokinematics that I can describe. Make sense? Yes. If I don't have arthro, there is no osteo. So if I don't have arthro, there is no osteo. If I can't move the joint, if I can't move it at the joint, there is not going to be any movement at the distal end of the bone. So Give me a live volunteer. Give me a human being. Somebody living and breathing. Come on. I don't bite, to my knowledge. At least not on me. Okay. So, come on, what I'm looking for. All right. So, this is live volunteer. Wave at the people. There we go. All right. So, now, do me a favor and go into shoulder abduction with the right. Okay. Try to just go up as much as you can. Okay. So, for that to occur, she has to have motion here at this part of the joint to allow for this motion to occur here distance. So now, if I take it and I hold the joint, I'm gonna lock the joint down. Now try to go into abduction. Can't do it. Why not? Thank you. Because the joint can't move here proximally, I'm holding the joint down. So my hand was doing this. I'm holding her joint. So when she tries to go into abduction, it's bumping into my hand and it's preventing the osteokinetic motion that she's trying to go in. So what happens at the joint determines what's going to happen with the range of motion for a lot of the motion. So I have to have good arthrokinematics so that I can have good functional osteokinematics that I can describe. Okay. All righty. Nobody lost. Yeah, okay, good stuff. Okay, so let's talk about the rules. So let's go back to the handout because the rules will make sense. Okay. So in a joint, so there's pretty much going to be two rules. So it says the rule is described as follows. A concave joint surface will move on a convex surface in the same direction as the distal end of the bone. I need to get to those. So jump down first. So let's start with the next paragraph. A convex joint surface will move on a concave surface in the opposite direction of the distal end of the moving bone. Let's start there. So a convex joint surface will move on a concave surface in the opposite direction as the distal end of the moving bone. Let's make that make sense. Okay. So I have a hip. The surface here, what will we call that surface? I agree. Thank you. That's, yeah, there we go. Like my daughter. It was a specific name of a dinosaur. I'm like, it's called a dinosaur. Concave, that's what I mean. Concave surface, we agree. Everybody agree? Concave. This surface would be convex or a good weapon. So concave, convex. Put them together. Now, when the convex surface moves on the concave surface, it's going to move opposite the direction of the movement that we're trying to produce. Okay, so let me turn it this way. So this will be looking at it from a lateral view. You'll be looking at it from this view. if I'm trying to go into hip flexion, taking my hip in that direction, this motion. Oh. So that motion of my hip is there. I'm trying to go into hip flexion. That's what I'm doing. My distal end of my femur is moving anterior, right? It's coming forward. Agree? Coming that way, coming towards you. But the head of my femur is rotating backwards towards me. See that? Doing that. So it's rotating posterior in the joint, while distally, my leg is coming anterior. That makes sense? When I'm dealing with convex, moving on concave. Yes. So when I'm dealing with convex, moving on concave, the joint is going to do the arthrokinematics is going to be opposite the osteokinematics. And we use basic terminology. It's either moving anterior, so let me write. So it's all going to move in certain directions. That's it. So the descriptive terminology is so it's either moving, so arthrokinematically, the descriptive terminology is not going to be things like flexion, extension, abduction, adduction. It's going to either be, it's going to be rotating, roll glass speed, so it's going to be posterior, anterior, inferior, superior, so it's either going to be rotating, it's either going to be, not rotating in general, it's either going to be moving either anterior, posterior, superior, or inferior. Right, right. So arthrokinematic motion. So I don't want to just limit, because there are going to be times when concave surfaces are going to be more convex. So don't just limit it to convex surfaces. Just think the way we describe arthrokinematic movement is either going to be moving inferior, superior, anterior, or posterior, or a combination. So arthrokinematic motion is either going to be moving superior, inferior, anterior, posterior. Okay. Let me zoom in here for my online audience. All right. Okay. All right. So for my online people, so this is for you all. Let me put up the picture. So now, we said this surface here is convex, this surface, concave, it's together. Okay, so I am going to be moving into hip flexion. So I'm going to be moving into hip flexion. The hip, if I'm moving into hip flexion, which is going to be this way, you see the head of the femur is going to rotate the opposite direction. It's rotating towards me. So all of this joint surface here is coming towards me. How will we describe that? Arthrokinematically, it's moving which direction? Posterior. Thank you. Yes. The hip is coming forward into flexion. That's an anterior motion. So arthrokinematically, it's rotating posterior. It's rotating towards me, backwards, posterior. Good. Let's take hip extension. So if I'm going into hip extension, my hip is going which direction? Posterior, agreed. So arthrokinematically, the joint is moving anterior, very good. It's rotating forward. It's going that direction, rotating forward. Make sense? Okay. If I'm going into hip abduction, so this is cool. So I'm holding here, I'm going into hip abduction. So the distal end of my bone is doing that. Which direction is the head of my femur? Inferior, very good. So as this is coming superior, it's coming toward the ceiling, this is going inferior toward the ground. Very good. Now, if I come from abduction and bring my leg back down into neutral, which way am I moving? Superior, absolutely. Yes. 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 Very good. Hang in here with me. Don't fall asleep. This is good information. Now, if I take my hip and I rotate into external rotation, I'm doing this. External rotation. How would you describe that motion? Anterior. Yes. Very good. The head of the femur is rotating towards you. Anterior. Very good. If I go into internal rotation, how would you describe that? Posterior. So when I'm rolling backwards, if I'm rolling into internal rotation, it's coming towards me, posterior. So you see what I mean? We can sum up arthrokinematic motion of all of the joints. It's either going to be moving anterior, posterior, superior, or inferior. But it's being able to look at the joint, see what motion is occurring, and then being able to describe it. Something you probably never had to do in your life before. We're going to help. So, again, if I'm going into abduction, arthrokinematically, you would call that inferior, right? It's moving inferiorly, arthrokinematic. If I'm going into internal rotation, posterior, arthrokinematics. If I'm going into hip flexion, posterior, very good. If I'm going into hip extension, anterior, very good. That's arthrokinematics when I have convex moving on concave. Vex moving on cave. Vex on cave. That's what happens. Now, what have happens when I have concave moving on convex. Because that can happen. There are a few joints in the body that allow that. Next, start getting into the the way you look at motion. I do not have to hold them. Let me find it. Okay, so now, here is humerus, this bone here, connecting to the shoulder. Let me zoom out here. See? Oh, wrong direction. Okay, so, here we go. Humerus, bone here, same thing, different color. Humerus, agree? This is the ulna. This bone here, agree? Okay, so what shape would you call this? Trochlea. Convex. Guessing or you know it? So this surface here, that's convex, I agree. This surface here would be, that's very easily concave, very good. So the ulna is easily seen as concave. It fits on the humerus like this, which is convex. So when I have ulna moving on my humerus, elbow flexion extension, the motion is going to be concave moving on convex. Makes sense? So this is a concave moving on convex surface. The elbow. So the elbow, concave moving on convex. Now the rule states when I am dealing with concave moving on convex, it's going to move in the same direction as the distal end of the bone. Whereas convex moving on concave is opposite directions. Concave moving on convex is going to be the same direction. Make sense? So now, let me put that on there like that. So when I get ready to do elbow flexion, my humerus, my ulna is moving what direction? Could be superior is more going toward the ceiling. I guess you could say that. What's an even easier one? Anterior, yes. It's going to meet the anterior aspect of my humerus. Anterior is a better description. So my ulna is moving anteriorly. And so is the joint that's connecting it. It's moving anterior with it. So when concave moves on convex, it's the same directionality, anterior. So when I go from elbow flexion into now elbow extension, what would be that direction? Posterior, very good. So elbow extension arthrokinematics is going to be posterior. Elbow flexion, anterior. Make sense? If it doesn't, we don't want to get to lab, we'll let you actually touch bones and it'll make a lot more sense. No. Not that cool. Okay. Can't see anything. I don't know, man. It may be your connection. We go. So, again, concave moving on convex is going to move in which direction? Same or opposite? Same. When I have convex moving on concave, it's going to move opposite. Very good. So once you know what's the shape of your bone, proximal and distal, that's going to help you to understand what's happening arthrokinematic. So once you know how to identify your bones, then you will easily understand what's happening arthrokinematically. It's going to really help make it make sense. Okay? Any questions there? We'll cover open and closed pack. It won't make sense until we actually lay you down to do it. Okay, so that'll be about it for chapter 4. We'll come back at 1. We'll do lab, and we'll start lecturing chapter 5. Any questions from our online audience? All right. At the 1 o'clock hour, I'm going to need to see your faces, unless you're in some weird position. So when you log back in this afternoon, you'll need your cameras on. Hopefully. There's some weird reason you can't, let me know. We want to see your faces. Facial expressions tell me a lot about your learning. All righty. Back at 1.